until October 2019. The plan was to collect more or enroll more patients and more follow-up, but they stopped follow-up after 2 months due to funding problems. So cohort 1, they had extra funding and continued 2 years of follow-up, while cohort 2 had only 2 months of follow-up. And this is one of the exclamation marks I'm putting here. For the inclusion and exclusion criteria, they included any adult patient with chronic limb-threatening ischemia and excluded those who are not fit for surgery. But here, the decision about fitness was according to American Heart Association or American College of Cardiology, or the medical judgment of investigator, which gives a bit of subjectivity about the decision of fitness. And for the randomization, patients were enrolled in one of the trials based on a pre-randomization duplex ultrasound to decide if the patient have enough great saphenous vein. And then patients who were enrolled in each side were having stratification according to clinical criteria, anatomical criteria, and then they were assigned to either open surgery or endovascular treatment using permuted randomized blocks, which is one of the methods of randomization. So 1:1 ratio between open surgery and endovascular treatment in each arm, and all patients were expected to receive the treatment within 30 days after randomization. And every patient decision was revised by 2 investigators, one expert in surgery and another one expert in endovascular therapy, to verify that there is clinical equipoise in the decision. In the open surgery, the surgeon was allowed to choose any bypass technique, and in endovascular treatment, it was the same, was allowed to choose any available endovascular technique, which is another question here about like the reproducibility of the study, because this will give a lot of heterogeneity. And the follow-up was done after 1 month, 3 months, 6 months, and 6 months after until the end of the study. For the outcomes, this is another thing, that there was a composite primary outcome. The main outcome was composite of major adverse limb event or death from any cause. And by major adverse limb event, it was defined as above ankle amputation or major index limb reintervention. Here, the need for reintervention was depending on the clinical assessment of the site investigator, and it was revised by a multidisciplinary clinical events committee for each first major reintervention. The secondary outcomes were major adverse limb event at any time or post-operative death within 30 days, or minor reinterventions or major adverse cardiovascular event defined as stroke, MI, or death from any other causes. For the statistical analysis, based on the power of 80 to 85 and to detect a difference of 25 to 30, they plan to enroll 2,100 patients. And the null hypothesis was that no difference between surgery and open and endovascular treatment. The trial enrollment stopped after about 1,800 patients due to lack of funding, as I said earlier, and supplemental funding was raised to allow 2 years follow-up for cohort 1 only. And for the statistical analysis, the confidence intervals have not been adjusted for multiplicity. This is something happened because of the composite outcomes. So the confidence intervals should not be used for hypothesis testing, which is another problem with the statistical analysis. So they assessed about 2,500 patients for eligibility, included about 1,800, 1,400 in cohort 1 and 400 in cohort 2. Of this 1,400 in cohort 1, divided almost equally between open surgery and endovascular treatment. Some patients did not have the planned treatment, so you will find in the analysis of the results according to intention to treat and the results according to as per protocol. So there is some missing numbers here. And then when you find about the patients who completed the trial, you will find about almost less than half of the patients completed the trial because of those who died or withdrawn or lost follow-up. So this is here in cohort 1 and the same almost in cohort 2. And these are the table showing demographics and medical history of the patients. We will not go through it now. And for the results, cohort index procedure was performed within 4 days for open surgery and within usually 1 day for endovascular treatment. Procedures for open surgery were between femoroobliteal, femorotibial, or popliteotibial bypass. 85% of the procedures were performed with a single piece of saphenous vein, which is another question that those groups were fit for a single piece. So only 85% had really gone to a procedure with a single piece of saphenous vein. And for the endovascular treatment, the vessels treated was about 500 SFAs, about 400 popliteal arteries, and equally tibial arteries. And the type of endovascular procedure depended on the segment treated, with no details at all about any technique, ballooning, or access, or anything. The endovascular interventions were done by vascular surgeons in about 3/4 of the patients, interventional cardiologists in 15% of patients, and the interventional radiologists in about 13% of patients. So the primary success of the technical success of the index procedure was 98% of the surgical group and 85% of the endovascular group, with no details at all about the reasons of failure, which is a big question mark here as well. Of these cases, 100 cases of early technical failure in the endovascular group, 66 were treated with a bypass within 30 days. So this graph shows us on the upper left corner the major adverse limb events. We can see that because if it's a composite between death and reinterventions, there is more reinterventions and less in the endovascular group, and in the surgery it is less. If we go for major reinterventions only, it is much more in the endovascular as we see. But if we go down to above ankle amputations and this, we will see that they are almost similar with no clinical significant difference. And here, this will show us the numbers as well of the primary outcomes and secondary outcomes. So the most important numbers we can say is about 9% of the patients had major reintervention in the surgery group, while about 23% of patients had reintervention in the endovascular group. And also the primary composite outcome, which is death and major adverse limb event, about 40% of the surgical group and 57% of the endovascular group. But if we talk about death only, they are almost similar. So for subgroup analysis, the primary outcome favored surgery over endovascular treatment effect across most pre-specified groups, except these groups did not show that similar outcome, which are patients elderly above 80 years old, Black patients, patients with recurrence of disease and previous revascularization, or grade 3 wounds or renal dysfunction. So going to the discussion, the authors started to talk about that surgery first strategy was associated with 32% lower risk of composite major adverse limb event or death. And in cohort 2, overall efficacy and safety outcomes appear to be similar. So, which means that those patients who does not have an enough segment of saphenous vein, you can choose between surgery and endovascular treatment according to the available expertise and patient preference and this stuff. Comparing with other trials, they found that the two groups had similar incidence of adverse cardiovascular events. And in cohort 1, the 30-day mortality or incidence of major adverse cardiovascular events or long-term survival at 2.7 years or similar to other studies in the registry. And for the surgical fitness, in agreement with other studies, the majority of patients who were predicted to have a good outcome from surgery safely underwent surgery, but they didn't again mention what was the method of assessment of fitness. And for the failure part, between the two groups, most pronounced for the endovascular failure, it was in the first 6 months, with 99 of 233 first 3 interventions done within the first month. So the initial failure of endovascular procedure was more pronounced. And this early increase in major reintervention actually have been related to a higher instance of initial technical failure in the endovascular group, about 15%, because as we said, it was only 85% success. but there was no mentioning about what was the technique used and why was the reasons of failure. Did they try and like distal access or what happened? Although it is likely that the majority of the major reinterventions were clinically driven, the choice of or timing of reintervention were based on judgment of treating physicians. So this is another point of subjectivity, and the causes were not known. So among the trial patients with adequate GSV who were fit for both techniques, bypass with vein was more superior. This is according to the authors of the study. And additional analysis is regarding anatomical patterns of disease and predictors of failure or effect of quality of life and cost is required. Comparing to other trials like basal trials, there was no significant difference in the basal trial between the primary outcome of amputation-free survival between open surgery and endovascular treatment, and this still like potentiates the complementary roles of surgery and endovascular treatment. The limitation, as mentioned by the authors, selection or and operator bias as a consequence of the study design. Eligibility was determined locally according to the site and individual investigator. And although the majority of patients had substantial infrapopliteal arterial involvement, an anticipated future review will show the degree of anatomical complexity. And as I said earlier, there was a procedural heterogeneity because each interventionalist or surgeon chose his own technique or his own bypass way. And the reliance on judgment of the individual operators, as I mentioned earlier, percentage of women were 28%, which was less than targeted, and the planned number of patients for enrollment was not met. And they also mentioned one point, which I'm not sure if it is a valid point, that publication of the meta-analysis about the relation between paclitaxel-coated balloons and death at 2 and 5 years by Professor Konstantinos Katsanos. So they mentioned that publishing this close to the end of the study may affected some centers using drug-coated balloons, but the study was published in December 18 and they finished enrollment in October 2019. So it's only the last year or 5 years of the study. In the conclusion, patients with chronic limb-threatening ischemia who had adequate single segment of saphenous vein fit for both open surgery and endovascular treatment. The initial bypass surgery was associated with lower incidence of major adverse limb events or deaths than endovascular treatment. And in patients without suitable great saphenous vein, there is no significant difference between both techniques. So regarding my own humble appraisal of the study, I think if we talk about some points, the study design, is it appropriate for the research question and answering the objectives? I think the answer is not because of the composite outcome and lack of objectivity in many things. The authors were equipped to conduct the study. Of course, they are big names and they are equipped for that. The study population, inclusion and exclusion criteria and methodology, again, there were some problems about fitness of the patients, question mark about this, and statistical analysis. The sample size was enough or not. The authors themselves, they said they couldn't complete the sample size that they plan to do. And are the measurements of the study, and this is an important question, are they reproducible or not? I don't think they are because we have many missing information that allow us of reproducing this study. And is the study conclusion addressed the study state objectives? Yes, they addressed it in the conclusion. And do I agree with the author's conclusions? I think in light with the provided evidence, I can't say that I'm certain of the conclusion, although what they said could be right. It could be right that surgery is better than endovascular treatment, but with this evidence we have in hand, we cannot generalize this results. And that's why I don't think this is gonna change my clinical practice. Thank you.
Thank you, Dr. Mahmoud. It's really very nice, an excellent presentation. I really appreciate that. You summarized it very nice. And you mentioned limitation, very well, and you said your appraisal. So let me ask you just one question. Do you think going to change your practice according to this one? And he said no.
Yes.
Is correct? Okay. But at the same time, you said you still think that the surgery is better than endovascular, correct?
I said that the conclusion they came up with, it could be right. I'm not saying it is a wrong conclusion. It could be right. And we all, as vascular surgeons, know that surgery has its rule and endovascular treatment has its rule. But we always tailor our decision according to the many patient factors and many things. But to use this RCT as an evidence, I don't think so. This is my disagreement. But we need more more arranged or more objective study to come up with such information if it will be.
Okay, thank you, Mahmoud. Let me move to the panelists now and see what their opinion about that, I mean, I'm sure there's a lot of criticism for this trial. I mean, it's a good trial. We've been waiting for that for many, many years to answer these questions. And I think they answered this question partially. I don't think they answered the question completely. But let's start with you. Who's going? Hisham. What do you think is the major withdrawal of this trial or limitation of this trial?
Thanks. Can you hear me?
Yes, we can hear you very well, Hisham. Go ahead.
You see, the problem with setting a randomized trial for critical leg ischemia it's never going to be a simple trial. You've got multifactorial issues involved. If you are trying to control it with aortic aneurysm or carotids, where the outcome is very clear, then you're never going to get the right trial in peripheral vascular disease, especially with critical leg ischemia. In my opinion, it's a very good study. It's got good numbers. They've done it perfectly well. And the conclusions are very clear. They actually match the conclusions of previous studies, like the PAVSS trial. And by the way, the PAVSS trial in 10 years analysis showed that surgery were actually more superior outcome than angioplasty. There are lots of registries that confirm the same. So I don't think it's a bad trial. I think it's a good trial. And the outcomes is very clear. My only concern is that peripheral vascular disease and critical leg ischemia is a very complex disease. For example, in my practice, the majority of our patients require hybrid revascularization, where actually both modalities are needed. You're talking about one modality for each, and actually it's not the reality anymore. The more complex stuff that we see, and I'm sure big units, and I'm sure most of the panelists sitting here, they see the similar, cohort of patients where they require very complex treatment. So I actually commend the authors for being able to do all of this. And I disagree with you, Mahmoud, that it's not conclusive. It is conclusive. And it is confirmed by the outcome in a big size sample, in a very complex situation, but they still managed to do it. And if you look at the data is very clear.
Hisham, I agree with that, but do you think that we are, comparing apple to apple? Because as I said, for lower limb ischemias, a lot of variation, depending how many runoff you are doing, how long is SFA occlusion? Are we talking about SFA and mobility occlusion? How is the arch? How is the wound? What kind of wound care they take? What's their skill? There's a lot of variations. So sometimes it's very difficult to compare apple to apple when you talk about lower limb ischemia. As you said, for carotid, for aneurysm, it's much easier. So do you think they did a good comparison? I mean, apple to apple, or do you think still a lot of variation in the,
their endpoints were easy endpoints. They were not complex endpoints. For example, if you're talking about healing and time to healing, that would have been very difficult because you have to grade all your tissue loss. But I can also remember seeing in a slide that they've excluded some of the deep ulcers from the trial to start with. So they were looking for simple things like limb salvage. They were looking for survival. So they were not looking into functionality. They were not looking into healing the ulcer, how long it took to heal. But they were trying to answer a simple question. How many patients died and how many patients kept their legs in the two groups and how many patients required re-intervention, which I think was very important. So I don't think we're ever going to get a trial that will look at such a complex cohort in a simple outcome So I think we're asking too much from the pathology itself to be randomized in a very rational or homogeneous way. You will never going to get that sample.
Okay, let me hear from the rest of the panels. Who would like to talk? All of you guys is open. Hani,
I have by me. And it's a great paper, and thank you, Dr. Mahmoud, for presenting it so well. But I would like to pose the question or the point that I don't think they've answered in this trial, which is, what do you start with first? Because, I mean, surgery versus endovascular, we do not need to be convinced that surgery is better. It's better long-term, and it's better with results, and better in all parameters. But what changed recently in a lot of people's practices is the fact that you always start with endovascular, and should that not be enough or fail, you still have the surgical option. The opposite is not true. So if you start with surgery, you've lost all your endovascular option. And that's actually been alluded to in the trial, because 66 patients needed surgical intervention following failure of endovascular intervention, but none of the surgical patients needed endovascular intervention. So in that sense, I'm not sure if that trial answered that question. In my own practice, and I lead a limb salvage center where we do a lot of peripheral interventions, we always start with endovascular. And over the years, we're very happy with the results that it will work in about 70%, 80% of the cases. And when it doesn't work, there is always a surgical option. And I wonder what the rest of the group think about that.
Thank you, Mahmoud. I agree. Part of that, I tell you, give an example. Like, I mean, if you have a patient with a single, lesion, and you think you can target with the endovascular, you can get successful outcome. I agree with you. I mean, no, you don't need to do the surgery. But patient comes with SFA occlusion, popliteal occlusion, he has single run-off. Don't waste your time with endovascular. This is what I think they want to say. If you're not assured you can get a successful endovascular, don't waste your time. He has a good vein, do bypass, and don't waste your time. So if you don't sure your endovascular will be successful, I think this trial tells us, don't waste your time, go right away to surgery. If you think you'll be successful with good result, then I think endovascular still, I think it has a role first, as you said. Hani, what do you think, Hani? A lot of hands open, yeah.
Yeah, yes, thank you very much for the opportunity. An excellent presentation and a very sort of debatable topic, and well done for choosing this as the first debate or webinar. There are a few points. The first thing regarding the design and the structure of the study, I have to say I would agree with Hisham that it's actually a very well-designed study. And what we have to be aware of is that if you have lots of information, what you have to do is your first publication is usually the very generalized one. So you come out with the bigger picture, the important message. But in terms of they have an endpoint, the outcome measure, they managed to achieve that. They managed to achieve statistical significance for all the outcomes that they wanted. So to some extent, I don't think we will get a more robust level 1 evidence than this. But I get the point whether this is applicable to what we do daily or not. There are a few things that we have to take in mind. Number one, the study lumped all the supragenicular and infragenicular in one group. I have no doubt that there will be multiple publications and subgroup analysis which will combine femoropopliteal with femoropopliteal endovascular versus femoropopliteal bypasses, infrapopliteal angioplasties versus infrapopliteal or tibial bypasses. But there are things as well when we interpret the data from this study we have to be aware of. So the main outcome measure, which was the major limb event, including the amputation or major reintervention, if you look at the definition of major reintervention, this was a bypass or revision bypass or thrombolysis or thrombectomy. So if a bypass had an ingraft stenosis and required angioplasty, this was not defined as a reintervention. And if a tibial angioplasty needed redo angioplasty, this was not required to define as a reintervention. One of the biases of the study is that you had a 15% failure rate in the endo group. And we can argue that probably this doesn't reflect real practice in most of our units, because this is a very high failure intervention rate. But even if we take this into account, this to some extent skewed the results against the endo group, because if you have a failed tibial angioplasty for someone or a femoral tibial angioplasty for someone with CLTI, your next option will be a bypass operation, which is the definition of major limb event. So it will count as a reintervention within the endo group. On the other hand, if you do a bypass and you have a 90% stenosis of your bypass graft, and this goes for angioplasty, this will not count as an intervention. So to some extent, you skewed the results towards sort of against the endo group as well. What I would really like to see, when I'm hoping that this will happen, is few things. Number one, instead of doing the analysis as per intention to treat, it should be done according to the actual treatments the patients receive. So those who had a successful angioplasty versus those who had a successful bypass. The second thing, they really need to split suprainguinal from infrainguinal, because all of us know that these are two completely, as you were rightly mentioning, these are apple we're comparing with oranges. So, and I'm sure this is something that will happen as well. And to some extent, it's very difficult to compare. So when we do the bypass, the technical success rate is something that you probably can anticipate beforehand, and it's very minimal, which is reflected in the results. But for the tibial angioplasty or the angioplasty or the endovascular group as a whole, I think it's important to just take away those ones who failed and look at the ones who had a successful angioplasty. The conversion rate as well was not commented on, but so some of the people who had failed angioplasty ended up with a bypass and vice versa. So I think what will really affect my sort of practice personally would be the analysis as per treatment received and the analysis as per the anatomical location, supragenicular and infragenicular. But as a whole, these are very difficult studies to be done, and they've done an amazing job, I have to say, to bring it to this level.
Thank you, Anya. Thank you very much. So I think what you saying that hopefully in the future we'll see more sub-analysis group.
Undoubtedly.
And hopefully this will answer more questions about this, what
absolutely
about it. Jamal, I see your hand up, Jamal. Please go ahead.
I think Isam had his hand up as well.
Okay, Isam.
For me, and then I would like to have others contribute.
No, Mr. President, you must go first, Mr.
Please.
Thank you, Mahmoud. Great presentation. I thought it was very good. I have to say I fall in 100% with Hisham. I think it's a great study, and I'll tell you what I like about it. It's a real-life study with an intention to treat in over 180 centers, and therefore I think is representative of what's going on out there. There are a few observations that I think quite interesting, keeping away from the main endpoints. One is that this myth of endo first is okay, I think now is questionable. I think in the presence of a good GSV, there's probably pretty compelling evidence now that maybe endo first is not as we think it is, and therefore it's pulling the pendulum back towards surgery first. The other myth I think it puts to bed is that surgery has a worse patient safety profile in the 30 days. And people say, oh, big bypass, he's better off with an angioplasty. This has shown there's actually no difference if you do surgery or you do an angioplasty intervention. So that's another idea that people walk around with. I too, Hani, was very surprised at the technical success rates of the endo at only 85%. I can only then say that surgeons who did 73% of these are not matching their interventional radiological colleagues. Is there something there? I agree with Mahmoud in the area that fitness was not clear. I've not had the chance to read the appendix and look at the AHA grading that they were using, but that's a very subjective measurement. So there were some patients excluded because they were deemed not fit, and we need to know more about that. Overall, I think it reinforces a belief I've had clinically. Around the turn of the century, 2000, we were doing a lot of femoral bypasses in Ipswich in diabetics, and we were monitoring very closely amputation rates, which Jerry Raymond published. And then came this endo wave, and everybody went for endo first. And after about a year, we started to see a rise in our diabetic amputation rates. And I felt that maybe the long-term and indeed medium-term results were not as compelling. If you don't have a good vein, then I think what this study suggests is that endo first, surgery first, they're probably equal. I get all the concerns about sample size, etc., but I think that they've, like Hani said, have been able to achieve statistically significant results. I don't like the fact that it's a very homogeneous group of white men, and that we don't know what it's like in Afro-Caribbeans, etc. I'd be interested to see what Hisham thinks about the end stage or the renal dysfunction, because I know he's published extensively on very good outcomes in renal patients. But this is saying that if you have renal dysfunction, you don't do well. And lastly, critical limb ischemia is a terrible condition, and the long-term survival is very poor. Best medical therapy was very poor in this group, and maybe we should focus on that as well. So that's what I took away from it. Thank you.
Thank you, Islam. Let Jamal talk, then I'll come back. Go ahead, Jamal, you want to add?
Sure. I think first, again, very nice presentation by Dr. Tolba and great comments by all the panelists. I think overall, my take on this paper is that it really reinforced, as mentioned earlier, some of our clinical beliefs and the importance of having a good segment of saphenous vein. But really, what it also does not tell us is that, or it tells us also, is that you cannot base everything on the saphenous vein. There are so many other factors that are involved that will affect your clinical practice and decision making. And let me expand on that a little. I think there is a difference even in the indications of this study between someone who has rest pain and someone who has tissue loss. Someone who has rest pain and has complex tibial disease for which you're going to go and do an endovascular intervention that may fail in 3 months is going to go back and have further reinterventions. But someone who has a little bit of a tiny sore on his toe and complex infrapopliteal disease that you go in and fix, and then it fails 2 months later after the ulcer has healed, that's a success story. So if I have someone who has a small tibial disease or localized tibial disease and a great vein, am I really going to do a bypass on this patient? I'm going to do a tibial angioplasty. While if I have someone who has extensive tissue loss, and has a good vein and complex looking pathology, then it's a different story. The other thing that affects the practice pattern that this study did not address at all is the cost. And I know in different countries you have different areas of different support system and different reimbursement system. But in our area and in our part of the world where many of our patients may not be covered and may not be covered by insurance, where cost comes in and is, you have a patient who has sold a parcel of land so that he or she can get this ulcer fixed or this situation fixed, and they come in with a fixed amount of money that they can spend. You cannot afford to say, okay, I'm going to go in and embark on this angioplasty complex and use all these kind of fancy wires and the balloons and matters, and then come up and say, well, it did not work, I couldn't cross it, or at the end say it lasted for 2 months and then you're back to square one. So these are some of the things that this paper cannot really answer and that determine a lot of times your practice pattern and the way we think and deal with it among here. Thank you.
Thank you, Jamal. Hisham, is your hand up or this is old?
It's my hand, yeah.
Okay, go ahead.
I think you're right, Jamal. Every patient has to have the treatment specially tailored for them. All the trials are doing, just telling us what outcome for each procedure should look like. I think one of the most important things, and I think Isam alluded to it a little bit, is actually training. So we know that from the people sitting in the panel and the people, or probably the young ones who are participating in this webinar, I'm not sure when was the last time they saw a plantar bypass, or if they even scrubbed in a plantar bypass. And we used to do a lot more. I'm still doing a lot more. Even in Kuwait, I'm doing lots of plantar bypasses, although we have the facilities to do low plantar angioplasties, and we're doing both. So it has to be a multidisciplinary approach. Every patient should get what really best for them based on the tissue loss, based on availability of a vein, fitness for general surgery in general. But also this trial will focus people now on training. Our young surgeons should be exposed to all aspects of bypasses, including the FemPop, the FemDistal, and the FemPedal, and what we call ultradistal bypasses. And I think this is one of the benefits of this trial, that now the registrars and the senior registrar will start asking questions about training. And I think this is a very good point for us to start focusing on. As for outcomes in renal failure patients and all this, it's funny enough, I tried to publish a study on Afro-Caribbeans and Caucasian, because I live where I work in London. We have a very huge population of Afro-Caribbeans. None of the American papers would take it, because there's a big bias in the literature in America when it comes to African Americans and Caucasian, because it's all to do with the insurance, and something that we don't have a problem with in the NHS. And we didn't find any difference, by the way, between Afro-Caribbeans and Caucasians. They have the same outcome. The only problem that we got with Afro-Caribbeans, that the outcome for minor amputation was higher, because you don't usually diagnose the early stages of ischemia in the toes as easy as in a Caucasian population. And that was the only outcome. And I will stop here.
Thank you. Thank you, Hisham. Munir, you want to add something, Munir? I see your name.
No, thank you. I'm enjoying the discussion. Thank you.
All right. So I think it's a very nice discussion, but this is give us back to the criticism we're going to be criticized by interventional radiology. If they look at this paper, I don't think they will take it lightly. They're going to say, guys, 80% of the cases done by endovascular done by vascular surgeon. And I think about 30% of the centers, they only have vascular surgeon, no intervention radiology or cardiologist. And then they may question our skills. And they may say, guys, 15% failure is very high, maybe because it's done by vascular surgeons. The reason why you have a better outcome with the surgery. Maybe it's a time to go back and, give the endovascular to intervention and guys stay with the surgery. And second thing, they may criticize us that, guys, as Mahmoud mentioned, that less than 50% of the cases they use a drug-coated balloon, and we know the patency is better because concern about mortality. There's a question about using atherectomy. Nobody use, but very few people use atherectomy. They may say, okay, as always, they criticize our trials that, industry getting better and our tools getting better. So by the time that, the trial finished, we have a new tools, we have a shock wave, we have a new technology which can improve our patency. So how we can answer this criticism from our colleague in interventional radiology? Let me start with you, Hani.
Yes, thanks, Samer. I mean, with the I don't think this is this criticism will stand because it's been published and the data before already published in the literatures with enough evidence to show that it depends on the training, and the expertise is nothing to do where you're coming from, whether you're a surgeon or a cardiologist or interventional radiologist. And I think we have to be careful what sort of conclusions we draw here. It's not because 73% of the investigators were surgeons. This means that these 15% of failures in cohort 1 and the 20% of failures in cohort 2 were done by or treated by vascular surgeons. There's nothing in the paper, as I'm aware, which shows that these patients were treated by vascular surgeons. So unless we have solid data to show that there was a significant difference in outcomes between surgeons or interventional cardiologists or interventional radiologists, I don't think we really can draw any conclusion on that. So, and if there's any doubt, the data is already there in the literature. And I'll probably argue the opposite way, in that it's not just the angioplasty, because those patients had CLTI, and I assume most of them had tissue loss. So you do a fantastic angioplasty, but you can't properly look after the wound and the foot and do the amputation and so on, and the angioplasty on its own will not work. And that's why I think we have to acknowledge that this is a good quality study, but on the other hand, this is the collective view. We have to wait for the subgroup analysis, and you have to remember that there is another study, another trial, which is the Basel II trial, and this is a more specific trial looking at the infrapopliteal revascularization, endo and open. And probably this is a study which will give us a more direct answer to this question if we're talking about the below-knee as well. Because as it stands now, best CLI probably is comparable to the Basel study, where they grouped sort of above and below knee together. So yes, there is evidence of superiority if you have very good quality vein, which almost every one of us know that. But if we talk about sort of who does the angioplasty, how can we sort of improve things, it will be more informative or more meaningful if we look at those who had successful angioplasties versus those who had successful bypass. And to be fair, this is what will change my practice.
Yeah, but see, the problem did not define the failure of endovascular. This is a problem here. So we don't know what you are talking about.
Sure, absolutely. But you can go back and maybe scrutinize why there was a failure. But on the other hand, as any sort of this is a pragmatic study, so you can't specify whether they use drug-coated balloon or not, or they use re-entry devices or atherectomy or vessel preparation. No, you have to go for best endovascular treatment versus best surgical treatment to reflect what really happens in day-to-day practice.
Yeah, but they may argue that 17% or 15% failure is not the best endovascular treatment. Right.
No, so those people did not have endovascular treatment. So to define best endovascular treatment, they have to have an endovascular treatment. So you can argue whether plain balloon angioplasty is the best endovascular treatment or not versus drug-coated balloon. But you can't lump those ones who had a failed endovascular treatment as those who had endovascular treatment, because they didn't. They ended up having bypass. And if you do analysis by the treatment they received, those 66 patients out of the 100 and something who had a failed endovascular treatment actually ended with a bypass. So their outcomes as per treatment will be in the bypass group.
Thank you, Ali. Isam, I see your hand up, Isam.
Yeah, so often I disagree with my brother Hani, but on this occasion, I might. I think from a patient's point of view, to say that if the endovascular treatment works, you're going to do really well, and if it doesn't work, well, it doesn't really matter. We can always bypass you. I think that sort of defeats the purpose. The technical failures in the endovascular group are either related to the patient, to the operator, or to the technique. What is factually correct, Hani, is that this technical failure rate is 3 times higher than other published results for success in endovascular treatment. So therefore, we need to look at why there is a difference. I agree with you. It may be the operator. The fact of the matter is that the overwhelming majority of the operators in this series were vascular surgeons. There were a few cardiologists and very few intervention rates. Now, that may be a surrogate marker for technical expertise, for training. It may not. It may be the patients were different, and it may be the issue is that they were not using the drug-coated balloons or atherectomies, etc. That needs to be looked at further. But as it stands at the moment, I can see the intervention radiologist saying, aha, we need to look at this further. So I would get ready for that. I would prepare for that.
Yeah, undoubtedly. I'm sure the authors are already looking into this data to look at it. But what I agree with you, I never disagree with you, Sam. What I agree with you on is that if you plan someone and you put a patient on the table for a bypass, and then you explore the long saphenous and for some reason it's thrombosed, and this is the only good quality vein, and the patient does not end up having a bypass, I wouldn't, to me, in my mind, if this patient carries on and doesn't lose the leg, I wouldn't call this the successful outcome of a bypass. And in all fairness, if he loses the leg later on, I wouldn't say this is an unsuccessful or a poor outcome for a bypass, because at the end, this patient did not have his bypass. And the same applies for endo. So if someone tries to open sort of an SFA and if it doesn't work, I wouldn't call that actually the endovascular treatment of the SFA has a poor outcome if they lose the leg, or has a good outcome if they don't lose a leg, because they didn't end up having the treatment. So the intention, yes, was to do a bypass. I get that. But because the vein was not usable and the procedure was aborted and didn't have the intended bypass, I can't correlate the outcome to the bypass, which didn't happen. I don't know whether I'm making myself clear or explaining it well or not.
Yeah, no, I understand that. And you're right. But I think Hisham's point here is crucial, that we're moving now into an area of much more hybrid operating. And in that respect, maybe this paper is already out of, behind the times, behind the curve, in that you'll often go to the hybrid and you'll try your endovascular, it doesn't work, you'll bypass, or you'll do a bypass and then a distal angioplasty. So I think that's a very, very cogent point.
Okay.
The other thing that's interesting here in this paper is if you look at the quality of life improvement for the successful bypass, they have a successful bypass, they keep their leg, but their quality of life did not improve. And that is odd, really. I can't understand that.
Because our sick patient, I think, Sam, you see, they're a very sick patient. adverse effect 40% in both group, surgical and endovascular. So I think was a very sick patients.
Yeah, but if you have rest pain and have a non-healing ulcer, and I heal your ulcer and get rid of your rest pain, I'd expect your quality of life to improve.
I mean, the reported mortality in this group of CLTI patient at 5 years ranges between 60 to 80%. So up to 80% of your patient that you do bypass or angioplasty with CLTI will not be existing in 5 years, sadly.
Okay, I see Munir, your hand up, Munir. Please go ahead.
Yeah, sorry, we were part of this study. We could not really continue in it because of the difficulty in enrolling patients. So patients, they come asking for endovascular first rather than to be randomized. But I want to disagree about the study. The study is very clear. It is comparing two things from the get-go in an equipoise patient. So the patient is good for both. That's why you have an interventionalist and a surgeon that they have to agree. Our case, the interventionalist was one of the cardiologists. We are also interventionists, but they wanted somebody other than a surgeon in the study. So that itself neutralizes the indication. The many patients we tried to randomize, we had to run by the cardiologist, although we can do both. So the intent to treat is much more important than the result of the procedure. Because the intent to treat here is everybody wants to do endovascular first, forgetting about the failures of the endovascular. In the US, the training for the endovascular in the lower extremities, there is no difference now between radiologists, cardiologists, and vascular. It's almost the same. Actually, the vascular surgeons are more aggressive endovascular than radiologists, honestly. And the cardiologist more aggressive than both. The failure might be a little bit high, yes, because of surgeons, because they know when to stop. They could not continue saying, I have an endovascular intervention. they say it's not working, let's try something else, or vascular. The heterogeneity part of randomization is very important, which means you cannot get the best result from an interventionalist and compare it to the best result with the best surgeon. You need to compare the average result of everybody in the country. So that reflects the real population of surgeons and interventionalists doing the procedure. The only issue with this study, which was a problem for us really, technology. The availability of technology is different in different locations, even in the US. Also, the use of technology is different between countries. I cannot compare the US, for example, to the Middle East, where the availability of technology comes with a very high price ticket, and you cannot do that. So it's a good study for the Western world where you can have both applied. And unfortunately, I can say also that in non-Western countries, in the Middle East and some other non-Middle Eastern countries that are having the technology problem because of the price, you cannot apply the study. You cannot apply the study. You apply the study to areas where you can have both. The final comment I have, we cannot go what is first. We go what is good for the population. What is first for the endovascular surgeon, the surgeon is surgery perhaps first, but for the same patient, it might be endovascular for a cardiologist. And those patients really only enrolled if they have a good vein. So if they don't have a good vein, you're not going to enroll those patients from the beginning. You can use a graft, but it means above the knee, not below the knee. So the study was well done study. The principal investigators actually were in touch with us on a monthly basis, telling us to enroll Farber, Alec in Boston. In every meeting, he says, go ahead, enroll, and we tell them we cannot. The patient won't let us enroll them, actually. That's my comment on the study.
Thank you, Mani. I really appreciate it. Thank you. Isam, I want to go back to you. As you said from the study, you mentioned that the best medical treatment was very poor in this group of patients. Only less, 30% they were still smoking, less than 30% were statin. So what do you think of the role of best medical, treatment in this guide of patient with critical limb ischemia? Do you think play a role? Do you think it's make a difference for us as an outcome also?
I think absolutely, especially if you're looking at a composite outcome that includes death and stroke and other things. We looked at this a while ago. We published very early on when risk factor management was not fashionable for vascular surgeons. It is very poorly done. And what is surprising, this was 2002. It's still very poorly done now. And it's very simple. It's just, antiplatelets and a statin. Maybe an ACE inhibitor, but that seems to have gone out of fashion. But that increases your longevity. It increases your life expectancy, and smoking and cessation. So I think that we as vascular surgeons seem to not focus on that so much. There was a study done in primary health that if you had an abnormal ABPI as a screening tool, this was in the US, it was a very accurate predictor of coronary heart disease and increased risk of MI, just ABPI. So I think it's not done well enough, especially in this part of the world. We don't seem to think it's our responsibility. And even before intervention, starting aspirin or a statin a few days before an intervention makes a big difference to outcome.
Yeah, I agree with that. I think we have to do more to get the patient before we get to critical limb ischemia. If we really optimize them and we do best medical treatment, maybe they don't get to this level, So I think we have to do our part, as you said, Hisham, I'll come back to you. What do you think about the endpoint in this study? They put male and death as an endpoint. You think this is the best way to categorize the endpoint for critical limb ischemia, or we need to use a different endpoint?
So the PAVSS trial used the amputation-free survival. So how many patients were alive with their trial limb still on? They used something similar. So they used the male and the MACE to look into outcome for these patients, which is more or less how many lost their legs and how many died, but for a cardiac reason, just to make it very specific. So it's nothing like cancer and things like that. So I think the endpoint is perfect. I mean, as I mentioned in the beginning, outcomes in peripheral vascular disease is very difficult. Carotids, you either die or stroke or you're fine. Aortic aneurysm, you die or you don't die. Nobody talks about people after aortic aneurysm living their life in a wheelchair because they were so unwell in recovery. But I think it's a good outcome. Lots of people talking about MALE, lots of people talking about MACE, and I think our juniors and our young registrars need to start to understand that these are the future outcomes, and I think it's fine.
Okay. Jamal, I see your hand up, Jamal.
Yeah, I wanted to get your thoughts on the patients with the end-stage renal disease, where here they were not clearly defined, and maybe Munir can clarify what was used as a definition. I may have missed it, but I couldn't see the definition exactly. And there's a difference between someone who has a creatinine of greater than 2, let's say, and someone who is end-stage renal disease on hemodialysis. And I was going to throw that to the group and see their thoughts on that in your decision making. I know you have CO2 angiograms, et cetera, but when you talk about end-stage renal disease, I think there's a difference between someone who has a creatinine of 1.8 or 2 and someone who is on hemodialysis.
Munir, you want to answer that, Munir?
Yeah, so the end stage in the study was those who are on dialysis or grade 4. So which is close to dialysis, that you don't want to touch them. And the other thing, the people in the middle were, even when we wanted to say possibly we can randomize them, we don't feel good to randomize them. We do not, because of the kidneys.
Mamoun, I see your hand up, Mamoun.
I just want to play devil's advocate here and throw a question to the panel, also very, very short answer. If you have a patient who's equivalent, in lesions and fitness and all parameters, where you can do either surgery or endovascular, and you're all very professional in both fields, interventional and vascular, which one would you start with first? Clinical practice, everyday practice. Samer, start with you. Which one would you go first?
I think I already answered Mamoun, and what I'm doing. If I see like that, I will have a good successful outcome from endovascular procedures. Small, limited lesion, I think I can, or like single artery, I can fix a good outcome. Then yes, I will go to endovascular first. But when patient come with SFA and popliteal occlusion, even though I know I can cross it, I can fix endovascular, but I know patency will not stay long. I will not waste my time. I take him for bypass. Second thing, how much tissue he has. If he has extensive tissue loss, I think I would consider surgery first, because no question in my mind, surgery will bring more blood than endovascular. The rest of the panelists, please. Hisham, want to answer, Hisham?
I agree with your last point about tissue loss. So we treat lots of sick diabetics and lots of patients who've come for a second opinion. They've already had something done. They've already lost half of their foot. What I call the lifespan of an angioplasty is not going to ever be long enough to heal such a wound. We go for a bypass straight away as long as we have a good conduit. Having said that, now we're doing lots of hybrid, as I mentioned earlier. So you only need sometimes like a 20 centimeter piece of vein to just do the last bit to deliver the high volume of blood down from a popliteal to a plantar artery. But every patient, and back again to Mamoun's question, it has to be tailored. It's not like I go in and let's say tomorrow I'll be doing bypass first or I'll do angioplasty first. each patient have got their own situation, have got their own, complexities, have got their own incapacitating either risk factor or something to do with their heart, or something to do with their vein. It has to be tailored for each patient. I think the idea of bypass versus angioplasty, it's dead, it's old. I mean, Hani knows that I was not interested in the Basel II trial because I couldn't really randomize my patient to a Basel II trial, because these are the very critical CLTI with, the crural vessels. You can't really go and say one day I'm going to do this. It's just that you'll be lucky to get in something working. I just want to say something. If we're not doing enough bypasses in our practice, you will notice that our amputation rate will be high. Units who do not do bypasses have got higher amputation rate. They deny it, but it's a fact. It's because we are not doing enough bypasses. That's why we're still losing limbs.
Thank you. Hani?
Yes, thank you. It's a difficult question, I have to say, to answer, because if we're talking about a lesion or disease limited to the femoral or proximal popliteal segment, I mean, we tend to, and Isam, I'm sure, would disagree and hate me for that, probably with Hisham as well, that we don't do any femoral to above knee popliteal bypasses. I'll just say that and then log off straight away. So femoral popliteal segments, the data is there out, multiple studies, multiple multi-center trials. They have a good outcome in terms of durability and amputation-free survival and limb salvage. For multi-level disease, I've been trained by Hisham and I'm biased towards the hybrid revascularization. And I think those are the ones who would benefit from it rather than doing a long bypass or multiple level endovascular treatment. For the tibial, in my heart, I know that tibial bypasses have better limb salvage rates, better survival, but we know that the limb salvage rate is comparable between endo and bypasses. So despite the fact that you probably would think for a tibial angioplasty or a tibial bypass or pedal bypass, I don't think the patients are fit enough to go for that. So certainly, if you have the background and the strategy that you can do the angioplasty without burning bridges and not screwing yourself up and losing any bypass options, this would be my first option.
Thank you, Hani. Isam?
Right.
After you.
Yeah. Okay.
This was a trap.
Yeah, it was. Yeah, it was a trap. Yeah. A fem pop above knee for critical limb ischemia is an oddity for me. Most patients who have critical limb ischemia have two-level occlusive disease. If your inflow is good, then you're missing a level of disease, either it's crural or malleolar, by and large. And I do agree that there's a gray group in the middle, the subcritical ischemics and all that, but I mean, not often are you in a position for, to do a fem pop above knee. But I mean, come back to the question asked by Mamoon. I take the view, again, it's multifactorial. I ask myself, what are the reasons that would not allow me to do a bypass on this patient? So obviously fitness is very subjective, and I think that's an area we need to do more research in. Renal disease frightens me, CKD3, B and beyond, I will say, okay. And then if I look at the patient and think, they're not going to last very long, if the angioplasty is likely to give some tissue healing just for a period of time until their time comes, I'll go down that route. The other point which Mu'tasim Bukhari mentioned on the questions, in this part of the world, follow-up is very difficult. So if you do an angioplasty and it starts to go down, you won't often know about it. So I'm more inclined here to give them a bypass if I can, because it's likely that I may not see the patient again. So that's my view. But we do discuss all our patients in an MDT. We have vascular interventional radiologists. We have vascular and endovascular surgeons there, and they will often push back and take the patient off me. And I'm very happy to do that if they feel they make a cogent argument.
Thank you, Isam. But remember how often you can see a good saphenous vein in patients with CLI. Unless what Hisham said, unless if you fix your inflow and then you end with a short bypass, and I'm sure we have a lot of patients. But if you're going to do film distal bypass, I don't think many patients have a very good saphenous vein.
Yeah, I mean, it's interesting. This is the cohort 2 we haven't talked about very much. And I've got some views on the cohort 2. I mean, I think that to be able to do composite vein grafts from the arm, do sequential bypasses, that is another level of surgical training and expertise. I know Malcolm Sims and others have demonstrated very good outcomes with those sort of composite veins, arm veins. I'm surprised, and I'm looking forward to seeing how many of these were arm veins, or whether we're talking about plastic below the knee or muscular cuffs. But I do think arm vein, I mean, I believe arm vein is better than an angioplasty for a femoral distal. I still believe that, but I'm open to have my mind changed.
Jamal, want to say anything about Dr. Mahmoud?
I agree with the way you summarized your approach to it at the beginning. I agree with what you said. I individualize, and which is also what almost everyone said. I individualize my patients and see what kind of tissue loss they have and how extensive, and what's the complexity of their pathology. And based on that, I would choose whatever seems to be going to give me the best result. And I agree with Isam that I still use arm veins every now and then. And in that situation, I figure out what's the shortest segment I can use, especially if I have extensive tissue loss where I need a good pulsatile flow on the foot and I need to heal that foot. So I think we're all saying very similar things in different ways. One issue I face here is every now and then is the mid-level renal failure patient, where they would be adamant that I should not use any kind of contrast for them. And I would say that in this situation, if they have a good vein, I feel much safer to just do a good bypass that will last them, rather than try to do CO2 angiography and have half and half pictures and try to make decisions based on suboptimal angio or give them any kind of contrast. But great discussion. Thank you, everyone.
No problem. Dr. Mus'ad Sulaiman, Mus'ad, I saw your name here. Do you want to add anything about our discussion today?
Yes, Dr. Samer, I have a few comments, although you already have covered all the aspects, but my principal question is that for how many of us is this study going to change our decision in our practice? This is the main point. This could break my mind to be changed toward the shifting if I'm doing a lot of interventional work. Would I shift toward doing more bypasses, or I can change my practice to more intervention by this? So I need to know what is the impact on the decision that can the study change our practice. The other thing that has been truly covered by Dr. Hani Zaid is that there are a lot of variables. They didn't actually compare the supragenicular against the supragenicular in the two cohorts. They didn't make the proper analysis. So many of the subgroup analysis are already in need to clarify and elucidate more. You cannot simply compare the supragenicular simple CTO even of the SFA and compare it as a success compared to a very distal bypass to the plantar or the medial or lateral plantar arteries. This is a true point you got to be elucidated. One more thing is the type of the lesion and how extensive, how many of the tibial vessels are involved in each of the groups. And the main part of choosing the exclusion criteria from the very beginning of the study, which is the saphenous vein, I believe this is a bias towards the surgical group because you didn't do the same for the interventional group.
Thank you, Masad. Your point very well taken. Dr. Omar, I see also your name. You want to add anything, Omar? Thank you, Omar. Thank you, Omar, for your opinion. Really appreciate it. But
Can I
unfortunately,
just say something here, Samir? Just very quickly, and I'd like to thank our sponsor. I'd like to thank our sponsor for this word, his kind word. Yeah. You know, Mohammed, I think you're probably right. I think you're probably, regrettably, I think you're probably right that in time it will die away. By which time there'll be tablets that'll stop it from happening, and there won't be anybody. We'll all be extinct. Jamal and Hisham and I. They'll write stories about these old men who used to do 6-hour operations.
I agree with you, Omar, but we cannot generalize. I mean, you cannot generalize. You have to take patient per patient. It's no questions. You know, I mean, you can't say surgery has no rule. You can't say endovascular has no rule. And the second thing, we're not talking about which is the best procedure. We're talking what's the best for the patient. You know, I mean, the most patient to do rehabilitation. This is important. What we are Omar, we're not discussing, you know, which one is this is the reason why I go back where the question asked Hisham, what is the endpoint? You know, we know that surgery bring more blood to the foot, but how much blood extra? How much we need? Do you need this extra blood or not? So maybe in the future we'll have something will evaluate and tell us how much need the blood, and this will be our endpoint. It's just to heal the wound, or you know, but you let, let's let Hisham, go ahead, Hisham.
I think what you should remember is not the patients that you succeeded to do, it's the patient that you failed to deliver on. The patient who should have had a pedal bypass. But the problem is that you see them, you don't treat them, and they go somewhere else, or they end up with a major amputation. So I don't mind people doing one modality, but I'm telling you, one modality is never enough to treat complex patients. I'm talking about the patients I see, and I've done 20 years at King's as a consultant. We were having a presentation in the House of Parliament, and somebody came and said, I don't have a radiologist. I'm doing bypasses for everyone, and that's in England. And that's fine. As long as you're getting the outcome that you think is good for the patient, that's fine. But I can tell you, not bypasses on its own and not angioplasty on its own is going to be enough. You have a big group in the middle that's called hybrid. They used to be 15%. Now, in my opinion, they're 25%. I'm concerned that you are missing a big chunk of patients that you're not treating. And I'm not sure if you know or you don't know what happened to these patients.
Thank you, Hisham. So I think let's wrap it up. I'd like just from each one to give us like 1 minute summary. What should we take from this, trials, and does it going to change our practice? Let's start with you, Hisham. You're already here.
I think the good thing about the study is putting people more into focus about what you should be telling your patients. You can't just go and say there's one only option for you, which is angioplasty. That's not true. We have more than one option. As I mentioned, we have, at the beginning, Mohammed, you mentioned the paper talking about either angioplasty or bypass. But again, there's a big chunk of hybrid that we need to talk about. The paper doesn't mention it. Basil never mentioned it, but that's the fact of life. They're only comparing either angioplasty or bypass. It's a very old-fashioned to compare angioplasty and bypass. Seriously, I don't think we have the time to compare angio and bypass. You are lucky if you can use one modality on your patient and save the leg. And this is what we should be talking about. But I think it shifts the focus back to bypasses. We are failing our patients by not delivering the high-quality bypasses that we should be offering them, either crural or pedal bypasses. We claim that's the only option we have, which is angioplasty. It's not true. And this is what the paper is saying. Angioplasty is not the only treatment of choice. You have more than one treatment. If people are denying the option of bypasses, you are actually denying treatment for your patient.
Thank you. Annie, 1 minute.
Yes, thank you. So what I will take away is that this is a very good quality, well-designed and well-executed study. What I'm getting out of it is that these are high-risk group of patients, and the outcome is not as good as we would like it to be. As I said, I really look forward to the subgroup analysis. It's very difficult for me to take this conclusion and apply it to all my patients in clinic next week because they will not all fall into this category. I would like to and I look forward to their data for the infrapopliteal and sort of femoral popliteal segment for those who the analysis built intention to treat. And I also really look forward to the outcomes of the Basel II trial because in my view, this is a more focused targeted study that will give us really a good guidance on how we treat patients with infrapopliteal disease as well.
Thank you.
And thank you for choosing this topic. It's very good.
Thank you. Isam?
Thanks. I think it's a great paper. It's real life experience. I think it's shown me that endo first may not always be applicable. I think it's highlighted the need for better ways of assessing fitness and longevity. And I'm hoping that in that respect, AI may come in the future with algorithms that can give you more accurate predictions of somebody's life expectancy. And I think that, the technical success of your endovascular procedures may not be as good as you think they are in real life. So there's something to look at there. And I think to the younger surgeons, you should try to strengthen that part of your armamentarium to be able to do at least a good infragenicular tibial bypass. And I look forward to Basel II, which I predict will probably support the outcome of this study.
Thank you, Sam. Mamoun, 1 minute.
It's an excellent paper. However, it has not changed my practice. I still go with the view, and Omar has put it more bluntly than I could. Endo first for two reasons. One, I think it's the signs of the times where the minimalist intervention that can give you the better result is what's warranted. And that's what patients want as well, as Munir alluded to. Because if you give the same arguments to your patients, of all benefits, risk, etc., they'll almost always choose the endo first. And having the skills and the ability to do your bypasses and your distal bypasses is essential, especially for the benefit of attendees and trainees. And you should always have it at hand, train in it. But I will go with endo first.
Thank you. Munir? 1 minute, please, Munir. Still there?
Maybe
left. Musad, you want to say anything at the end, Musad? Dr. Musad? Maybe it's not here. Okay, I'll leave the last word to our president, Jamal. You need to summarize it and give us your fruitful, fruitful.
Well, I think I really, again, want to thank you for choosing this topic. This was a most interesting topic, very valuable to us in the Middle East, where diabetes and chronic limb ischemia is a very prominent pathology and important pathology. I think that, to me, I think this is a very interesting paper, but as we all have mentioned, ultimately we need to individualize, and I would summarize it based on 4 factors. One of them is the presenting symptoms degree, which is how much tissue loss and whether rest pain or how much tissue loss. The second one is the degree of pathology in the infrapopliteal disease, how extensive it is. The third one is the presence of vein. And the fourth one, which we tend to underestimate and not comment on, is the cost. I think having, with all my respect to my friend Dr. Omar, having 5 endovascular procedures in 1 year is not a success that we can brag about. I think that someone ultimately is going to look at you and tell you, where are you spending our taxpayers' dollars? You can't do something 5 times in a year and use each time $15,000, $20,000 worth of products and equipment. So thank you again for a great moderating, for great moderation, Samir. And
thank you. Thank you. At the end, it gives me a great pleasure to thank who present this paper, Dr. Mahmoud Tulba. Thank you for your really effort. It was very nice. Thank you for the panelists. And I will take this to announce that our journal club will be every 2 months. Correct, Jamal? And
yes.
And next month will be a webinar. Will be like, go ahead, Jamal. You want to give them a summary? What will be our activity?
Yeah, we're planning to alternate. 1 month have a journal club, the other one is a webinar. We will announce the session of the next speaker in February next week. We already have one committed for April. Stéphane Hollande will be our speaker for April, and we are finalizing our speaker for February. So this is going to be alternating with journal clubs that Samir will be moderating, and we'll be using this type of format. Hopefully everyone will enjoy and will have your participation. You are the key players in this, and hopefully our attendees, all the junior residents and registrars and junior faculty and senior faculty will benefit from our overall discussion agreement or changes of thoughts.
And our annual meeting, Jamal?
The annual meeting is planned for September 22, 23 in Dubai, and we're at the Conrad Hotel, and we're making all the arrangements. We have a scientific committee that's already starting to work on the program, and we should have a preliminary program within the next few weeks.
Thank you, Jamal. And with this one, we come to the conclusion of our meeting. And thank you again, and thanks for our panelists and all the attendants. Thank you very much, guys. See you.